Good morning, good afternoon, and good evening, everyone. Welcome to another episode of Teaching Points Recap VMR. For those of you who don't know me, I'm Dino, and I'm one of the Academy members. And today is a very exciting day because we have two of our new Academy members, Abir Al Musleh and Ethan Chu, who are going to be doing their first Teaching Point Recap VMR presentation. So we're really excited for them to be teaching us today. Other than that, for those of you who are new to this, what are Teaching Point Recap VMRs? These are not the regular virtual morning reports that we have. These are recaps of some previous cases that our Academy members choose, and then they reflect upon the teaching that went on and try to reinforce and sort of recap and do a spaced repetition for all of you. So I'm going to get started, guys. And before we do, I'm going to have Ethan and Abir introduce themselves to us. So go ahead, Ethan. Tell us a little bit about yourself.
Hello, everyone. My name is Ethan, and for those who don't know me, I'm a last year medical student from Taiwan. And outside of medicine, I like to running and just spend time with my families and friends. Yeah, so really excited to share my first teaching point recap with everyone. Yeah, so I think I just share my screen and get it.
Ethan, I just want to say that your voice is a little shaky. I don't know if it's just me. Maybe you want to check your internet connection quickly. I don't want your presentation to I don't want to have you pause again and again. Before we get started, I want to do Abir's introduction as well. Abir, tell us a little bit about yourself.
Hey, hello everyone. It's a pleasure for me to be here with you guys. I'm Abir Musleh. I'm international medical graduate from Palestine. Also, I am one of the TB Solver Academy member, and I'm coming PGY internal medicine resident. Outside of medicine, I love singing, painting, and travel whenever it's possible. And this is my first teaching point, as Ambush mentioned, and I'm excited to share with you guys.
We're equally excited to be here, and it excites me even more that you like to sing because I also like to sing. Hopefully one day we can have a singing session as well. So guys, let's get started. Ethan, you can share your screen and let's get started.
Think. All right. So, okay. I think can you guys see my screen? Yeah.
Yes.
And is my voice still shaky now or?
No, you're good. Go ahead.
Yeah, okay. So I'll just start it. And today I'm gonna recap a case on April 11th, presented by Hans and discussed by Robbie and Almo. And I want to recap this case because I'm really interested in gastroenterology. And I think this is a topic that is worth discussed and really want to share with you guys. So if you guys have any questions, just please put it in the chats and so I'll see it. Yeah. So let's just get started. Okay. So first I want to review the case first. So we have a 50-year-old male with hypertension presented with throwing up blood for 1 day. And in the history, we know that it's the first time of hematemesis of the patient, and he threw up total amount of 2 cups of fresh blood. And he also experienced several attacks of epigastric pain relieved by ibuprofen with no exaggerating factors. And in the review of systems, he also experienced fatigue, occasional mouth sores, and dysuria, which was treated with antibiotics. And in the past medical history, he had hypertension, and he denied past history of liver disease or alcohol use. So in a patient throwing up blood, first we need to determine the source of bleedings. If it's from the respiratory tract, it's hemoptysis, and if it's from gastrointestinal tract, it's hematemesis, which is the case here. In hematemesis, there are 2 differential diagnoses we need to rule out first because of how dangerous they are. And the first is esophageal variceal bleeding, and which is most common caused by cirrhosis, and we have to look for signs of that. And the second is aortic enteric fistulas, with the primary cause usually caused by abdominal aortic aneurysms, and the secondary form, which is most commonly caused by aortic reconstructions interventions, which the patient did not have that history here. And to rule out the two differential diagnoses, a EGD is the most useful tool to rule out that. So we'll definitely need that. And also another common cause of upper GI bleeding is Mallory-Weiss syndromes. But with the no alcohol use, the history of no alcohol use here, the diagnosis is less likely. And the patient has been taking hydrochlorothiazide for his hypertensions. And if in physical exams, the patient is febrile, has a low blood pressures, has mild jaundice in general appearance, and has mild hepatosplenomegaly in abdominal exams. So with a patient throwing up blood with low blood pressure, we need to start IV fluids, IV PPIs, blood typing in case the patient needs blood transfusion with active bleedings. And with the findings of hepatosplenomegaly, it increased the possibility of portal hypertensions. And with that in mind, we should start treat the patient with IV octreotide empirically because the fear of esophageal variceal bleedings. Also, one point to note here is that hematemesis itself represents rapid GI bleedings because it's due to blood accumulation in the stomach causing gastric distensions, with the exception of esophageal irritation if the upper GI bleeding is caused by esophageal irritation causing throwing up blood. Okay. So let's go on to the labs here. So in the labs, we found that the patient has pancytopenias, mildly elevated aminotransferase, hyperbilirubinemias, and normal LDH and albumins. So here we have a presentation of liver disease plus pancytopenias, and we can explain by two possibilities. The first is portal hypertension causing splenomegaly and hypersplenisms. The second possibility is a hematological disease causing infiltration of the reticular and endothelial systems. But here, with the normal albumins and normal coagulation studies, a decompensated cirrhosis is less likely. And with their normal LDH, a hematologic disease is less likely here. So we enter the category of non-cirrhotic portal hypertensions. And then we arranged EGD and abdominal ultrasounds. And in EGD, it showed esophageal varices, and in abdominal ultrasound, it showed hepatosplenomegaly and a hyperechoic thrombus in portal veins. So here, the question might be that why, if there's only a thrombus in portal vein, which is a prehepatic vascular structures, then why is the liver enlarged as well? And there's two explanations. One is due to extramedullary hematopoiesis because the patient also have pancytopenia. And another possibilities, Robbie, you mentioned that in the case discussion is that maybe there's a missed hepatic thrombus that is not detected in the abdominal ultrasounds, causing the enlarged livers. And the most common cause of hepatic thrombus is Behçet disease. Also noted that the most common cause of portal vein thrombosis is schistosomiasis, and then myeloproliferative disorders. And in the hospital course, the patient developed skin rash around peripheral IV, which was seen as a positive pathology test. And with combined the history of dysuria seen as urethritis and recurrent oral ulcers, the patient fits the criteria of Behçet disease and then was finally diagnosed with that. So I want to briefly discuss the pivot point of the case, which is non-cirrhotic portal hypertension. So we have to know what is portal hypertension first. And portal hypertension is defined by a portal venous pressure gradient between the portal vein and the inferior vena cava exceeding 5 millimeters of mercury. And the parameters, hemodynamic parameters is can be set as HVPG. And the most common cause of portal hypertension, as we know, is cirrhosis, which accounts for 90%, and the rest 10% is caused by non-cirrhotic portal hypertension. So when should we suspect that a patient has non-cirrhotic portal hypertension? It's when the signs of portal hypertension is present. For example, in this patient, esophageal varices and hypersplenism. But liver dysfunction cannot be established on physical exams. For example, pulmonary erythemas, spider nevis, gynecomastias, etc., or lab testing, for example, low albumin, elevated INR, or elevated bilirubins. Or if the patient has ascites and we did a paracentesis, and the ascites protein is greater than 2.5 gram per deciliter, which suggests hepatic outflow obstruction. That would also point to non-cirrhotic portal hypertension. As we know that in cirrhosis, ascites protein should be less than 1.5 gram per deciliter. And what are the other clinical features that could differentiate cirrhosis and non-cirrhotic portal hypertension? If the patient have a giant splenomegaly, it is usually caused by non-cirrhotic portal hypertension. And in abdominal ultrasound, if the finding shows a regular liver surface and homogeneous parenchyma, it would also suggest non-cirrhotic portal hypertension, as we know that cirrhosis would cause a irregular liver surface and usually a heterogeneous parenchyma. In endoscopy, the stomach is where the two conditions differs. And if we see gastric varices, that is more common in non-cirrhotic portal hypertension. And in cirrhosis, portal hypertensive gastropathy is more common. And liver biopsy is the ultimate test to differentiate the two conditions. And if we did a transtubular liver biopsy, we can obtain hemodynamic parameters. And if HVPG, which was mentioned in the previous slides, if this parameter is less than 10 millimeter of mercury, that would strongly suggest non-cirrhotic portal hypertension. Cirrhosis, this parameter should be usually greater than 10. Okay, so maybe we can, you can share if anyone has any thoughts of the causes of portal hypertension, non-cirrhotic portal hypertension, you can put in the chat, and I'll just introduce them. Yeah. So okay. Yeah. Yeah, nodular, yeah, Andrew mentioned in the chat, nodular regional hyperplasia is definitely something that could cause non-cirrhotic hypertension as a hepatic causes. So we can think about the causes of non-cirrhotic portal hypertension in an anatomic approach. We can divide it into prehepatic causes, hepatic causes. We can then divide them into pre-sinusoidal, sinusoidal, and post-sinusoidal, and then post-hepatic causes. In pre-hepatic causes, the structure includes like portal vein, splenic vein, etc. And in post-hepatic causes, it is usually the hepatic veins. So what are the prehepatic causes of non-cirrhotic portal hypertension? It includes like portal vein thrombosis, splenic vein thrombosis, splenic AV fistula, or massive splenomegaly. So here you may have the question that why a splenic vein thrombosis could cause portal hypertension, since it's a downstream vascular structure of the portal vein. And it's because when there's a splenic vein thrombus, it produces rerouting of the venous flow through other veins, like short gastric veins and gastroepithelial veins, causing left-sided portal hypertension. And in splenomegaly, it increased the blood return of the spleen and then causes portal hypertension. And in hepatic causes, the pre-sinusoidal causes include like developmental abnormalities like adult polycystic liver disease, AV fistula, like biliary diseases, neoplastic occlusion of the portal veins like lymphomas or CLL, or granulomatous lesions like schistosomiasis and sarcoidosis. And noted here, schistosomiasis is the most common cause of non-cirrhotic portal hypertension worldwide. And other causes include idiopathic causes and hepatoportal sclerosis. Yeah. So sinusoidal causes is a rare cause, and includes sinusoidal fibrosis caused by, for example, alcoholic hepatitis, etc. And also it could be caused by sinusoidal infiltrations by mastocytosis, amyloidosis, or it could cause by sinusoidal compression by enlarged Kupffer cells or enlarged fat-laden hepatocytes. And in post-sinusoidal causes includes veno-occlusive disease, sclerosis of hepatic veins, vascular malignancies, and granulomatous phlebitis. And in post-hepatic causes of non-cirrhotic portal hypertension includes IVC obstructions, other heart causes like right-side heart failure, pericarditis, tricuspid regurgitations, and restrictive cardiomyopathy. Yeah, so these are like the brief summaries of non-cirrhotic portal hypertensions. And there are three main take-home points I want to share. And the first is that when should we suspect non-cirrhotic portal hypertension is that when the signs of portal hypertension is present, but the dysfunction cannot be established on physical exam or lab testing. And the most common cause of that is hepatic schistosomiasis. And when approaching non-cirrhotic portal hypertension, we should use an anatomical approach to think about it. And these are my references. So thank you, everyone. And if you have any questions, feel free to just put it in the chat. Yeah. So yeah, I think Ashman says that if there's drugs involved in non-cirrhotic portal hypertension, and yeah, there's some drugs like Lina says, for example, like methotrexate and amiodarone could cause like sinusoidal fibrosis, etc. Yeah. And Leah asked that if portal vein thrombosis, how does portal vein thrombosis cause portal hypertension? Yeah, I think portal vein thrombosis itself, it causes like congestion of the portal vein, and that would cause portal hypertension. Because it could cause elevations of the portal vein pressures, which is PVP here. Yeah. Okay. So I think that's it. So if you have any questions, just put it in the chat and I'll stay here. Yeah. Okay.
Thank you, Ethan. That was such a fantastic presentation. I mean, I don't even have to tell you, you have so many fans in the chat. We have some of our very senior members, Dr. Ravi Singh, who are here, and they were very happy with your presentation. Dr. Ravi said that your slides were great, and you were explaining very well. Everybody was paying so much attention. We were all focused. So thank you so much for simplifying such a complex topic, non-cirrhotic portal hypertension. I used to always struggle with it in med school and still do. And thank you for sharing some of the most common etiologies, things like most common cause of portal hypertension is hepatic cirrhosis, most common cause of non-cirrhotic portal hypertension is schistosomiasis worldwide. So, those are some of the very key facts to have on your tips when you're dealing with such cases and pathologies. So thank you again, Ethan. I hope that you can join us again for another TP recap because this was amazing. You're such a natural at this. Moving on. We're going to have Abir present next. And as always, we have 3 presentations in each TP Recap VMR. The third presenter is a surprise, and I will reveal it after Abir is done with hers. So Abir, please go ahead. The stage is yours.
Okay, thank you, Anfash. And I would like to thank Ethan for the great presentation before I start sharing my screen. It was really amazing. So can you see my screen?
Yes.
Okay. So for today's teaching points recap, I showed the case that wasn't presented in virtual morning report in April 26, and it was presented by Himun, and it was discussed in a phenomenal way by Dr. Rafi and Prof. Raz. So first, we are going to start with a 60-year-old man, known case of hypertension and heavy alcohol use, presented with 2-year history of intermittent joint pain, and he's now experiencing asymmetrical pain in multiple joints, left knee, left wrist, and both ankles, and painful nodules in the lower extremities, specifically in the left lower extremities. The patient looks well, hemodynamically stable, and in physical exam, nothing was significant other than these nodules. And as Himun mentioned, these nodules mimic to erythema nodosum. And there was a swollen in left knee joint. Other than that, everything was normal. Even lateral flexion test was within normal limits. and there was no other rashes like psoriatic rash or any nail pitting edema, nail pitting. So here we are dealing with two buckets. The first one, joint pain. The second one was rash. In our patient was painful nodule in the lower extremities. And joint pain, when we are dealing with the joint pain, not every joint pain means an intra-articular issues like joint disease, as it can be easily as diffuse tendon or diffuse ligament or even diffuse bursa issues or disease. So we called arthropathy, and we divided arthropathy into three categories based on the number of joints involved. So if we have one joint that affected, we call it as monoarthropathy. More than 8 joints, we called it as polyarthropathy. And if we have more than 1 but less than 8, so we are dealing with oligoarthropathy. And this is the case that we are dealing with in this patient. So here we may ask why we divided into these three categories. That's because each one of these categories has a unique differential diagnosis, which will guide us and help us during investigation. For example, the monoarthropathy is often resulted from osteoarthritis, and in acute setting may result from crystalline diseases like gout or gout, or even unusual synovial joint disease, and for sure infection. For polyarthropathy, it almost always from autoimmune disease, and the exception for that, viral infection, like parvoviral chikungunya fever, and we consider it as self-limited polyarthropathy. And for oligoarthropathy, this category is set in a place between monoarthropathy and polyarthropathy. So oligoarthropathy share with monoarthropathy crystalline disease, and from polyarthropathy autoimmune disease, but in different variety like spondyloarthropathy family, or even other autoimmune disease like granulomatous autoimmune disease such as sarcoidosis, and for sure infectious etiology like septic arthritis, disseminated gonococcal infection. In other hand, when we are dealing with rash, which is a second bucket here, when the patient report rash, the most important thing is to look at this rash because morphology will influence our differential or our diagnosis. So here we are dealing with a case, as Human mentioned, that mimicked to erythema nodosum. So we consider erythema nodosum and its differential. So erythema nodosum, it's a common form of paniculitis, and it's like a hypersensitivity reaction to an antigen. So it's important to know if our patient takes any medications like sulfa drugs or even OCPs, or if he has known case of like sarcoidosis or other systemic illness, inflammatory bowel disease, polyarthritis nodosum. And for sure, we consider other erythema nodosum-like differential, like erythema anduratum, which is secondary to tuberculosis. What make erythema anduratum unique from erythema nodosum? That erythema anduratum can be easily alterated, and it appears in the posterior surface of the calf, not in the anterior surface of the calf. Other causes like paniculitis caused by alpha-1 antitrypsin deficiency, pancreatic paniculitis, paniculitis like subcutaneous lymphoma, migratory thrombophlebitis, and even simple benign causes like insect bite, bruising, leukemic cutis, when leukemic cell infiltrate dermal and subcutaneous layer. So here, how can we link between these two pockets? First thing, from the patient's presentation, as he is hemodynamically stable, febrile, and even the laboratory findings shown there is no sign of inflammation, we can rule out or decrease the possibility of infection. On the other hand, from the physical exam, as we can see that he doesn't have any finding that related to spondyloarthropathy family, lateral reflection test was normal, and no other finding related to that. In addition, the laboratory finding also decreased the possibility of spondyloarthropathy family, but doesn't rule out other autoimmune disease like sarcoidosis. So the next step was to order chest X-ray, and the chest X-ray was normal. There is no sign of hilar adenopathy. So here we are dealing most probably with a crystalline joint disease. And the most common cause of a crystalline joint disease could be gout. As let's take a step back to the social history to this patient. His known case of alcohol use disorder, which give an association with gout or other crystalline joint disease. And here's the bonus point about crystalline joint disease. Gout can be present as oligoarthropathy and also can cause paniculitis, which is called gouty paniculitis, which is unusual manifestation of gout, and most commonly present either precede or subsequently of chronic typhus gout. So in such case, like this patient, first thing we will think of common things like gout, and then unusual manifestation of common things, and then after that we may think of unusual disease or rare entity of crystal joint disease. So for that, we tap the knee joint and we see the yellow creamy synovial fluid, yellow creamy synovial fluid, and was sterile with no crystal. So the possibility of a crystal joint disease like gout decreased. And then we take a skin biopsy, and while waiting the skin biopsy result, the patient treated with NSAIDs and steroids. But 1 week later, with no improvement, the patient presented again with a new complaint, and it was more diffuse abdominal pain without radiation, without nausea, and vomiting. So here it's crucial to look what's going on inside the abdomen and to look specifically inside the liver. And the abdominal CT findings showed acute pancreatitis complicated by pseudocyst and fistula and even mesenteric thrombosis. And the serum lipase level was highly elevated, 23,000. So now, how can we join these dots together? Let's say acute pancreatitis with polyarthritis with paniculitis, polyarthritis or even oligoarthritis. So this given us the final diagnosis, especially if this patient have a history of heavy alcohol use, which is PPP syndrome, triple Ps. And today I will teach you a little bit about PPP syndrome. PPP syndrome most commonly occur in patients with heavy alcohol use, which lead to pancreatitis or even malignancy. And this pancreatic issue will be as a trigger for this syndrome. And for sure, to not miss that heavy alcohol may lead to other crystalline joint disease like gout arthritis and unusual manifestation like gouty paniculitis. So let's back to PPP syndrome. The first P would be pancreatitis or even pancreatic malignancy. The second P would be paniculitis, and the third P will be polyarthritis. So what is PPP syndrome? It's a very rare symptoms complex of extra pancreatic manifestation of pancreatitis with lobular paniculitis and polyarthritis with intraosseous fat necrosis with an incidence of 0.3% to 3% across a range of different pancreatic disease. And most of the patients are middle-aged men, and 64% have a history of alcohol abuse. The mortality rate of PPP syndrome has been reported to be up to 24%, which is primarily due to underlying pancreatic disease. So what is the etiology behind that and the pathogenesis? Until now, there is no clear reason for that, but some etiology related to some pancreatic issues, like either pancreatitis, either acute or chronic, or even pancreatic malignancy, which lead to auto-activation of pancreatic enzyme and then release. So trypsin, phospholipase, amylase, and lipase work as a synergistic rule together. Trypsin and phospholipase will erode the blood vessels endothelium, which allow lipase to enter into peripheral circulation. Specifically in the location that filled with adipocytes like subcutaneous fat tissue and periarticular area and medullary fat in the bone marrow. So just as a reminder, there are a lot of adipocytes in and around the joint that help that's softening the motion of the joint. So when the lipase enzyme destroy this adipocyte, this lead to to so we can get a yellow discharge that we get it from the synovial fluid from our patient, and ultimately lead to joint destruction. So, and now I will let you know how can we deal with this patient. And if you see the patient that suspect having PPP syndrome, the first thing, physical exam. And the most clinical finding would be skin manifestation, like our patient. And the second thing would be joint pain and swelling. And less commonly would be sinusitis or eosinophilia as a laboratory finding, abdominal fat necrosis, mesenteric thrombosis, and bone marrow fat necrosis. Second thing would be labs. The most important thing would be a simple test here, which is a serum lipase, which will save a lot of time and even life and even money. So from the lab, from the laboratory or lab test, we can rule out other differential diagnosis and rule in this diagnosis or confirm the PPP syndrome. And then we want to visualize what is inside the abdomen, what is going on inside the pancreas, about pancreatitis, if there is any inflammation, masses, or even metastatic disease. And for sure, tapping the joint, which will be as a sterile creamy substance that contain amylase lipase free fatty acid without any crystals. Skin biopsy will show lobular paniculitis without vasculitis. And also will appear a ghost adipocyte, which is adipocyte that's losing their nuclei. And here I would like to add a bonus point that Prof. Raz mentioned. It indicate when we should make a biopsy in the lower for the cases like erythema nodosum, when it's involved in the site other than legs, or if the erythema nodosum ulcerated, because classically blood vessels not involved in erythema nodosum pathogenesis, or if it's persistent than 8 weeks. So what is the possible complication that may occur with PPP syndrome? The same complication that may occur with pancreatitis or even pancreatic malignancy, because sometimes pancreatic paniculitis not investigated properly, so which lead to delay in diagnosis. So it will be infection, pancreatic necrosis, fistula formation, pancreatic insufficiency failure, pseudocyst formation, metastatic disease. And there are a rare complication, which is a rare lipase, which is lipase hypersecretion syndrome, which is a paraneoplastic syndrome, most commonly occur with acinar cell carcinoma, which composed of triad of eosinophilia, polyarthritis, and paniculitis. And now I will let you know how we manage and treat this patient, which the cornerstone of a treatment will be to treat the underlying pancreatic disease. As we shown in our patient, Timon mentioned that after surgical intervention, including a stent placement and given the patient anticoagulant for mesenteric thrombosis, the patient shown a significant improvement in his condition, and even the lipase level decreased. Regarding the skin lesion in patients with acute pancreatitis, this appears when the inflammatory phase is over. But what about using NSAIDs, steroid, or other pharmacological treatment, or even immunosuppressive medication like colchicine? And if so, if we can use it, when we can use it? There is no effective management strategy, so it cannot help in we cannot use it as a cornerstone of treatment if we didn't remove or stop the original source of trigger, even pancreatitis or malignancy. But we can use it if these painful nodules was painful. If this nodule was painful, so we can use it as an analgesia. About the prognosis, the same, depend on the etiology of pancreatic disease. So the prognosis in case of pancreatic cancer would be more worse than pancreatitis. So in either if the etiology from pancreatitis or malignancy, early diagnosis will make a huge difference. So when we deal with a patient presented with polyarthritis or even polyarthritis with panniculitis without any abdominal complaint or GI symptoms, we must consider PPP syndrome as one of the differential, specifically if we deal with patients with heavy alcohol use, alcoholic patients. So take home message, as Dr. Rabi said, your job first to rule out morbidity like infection, and then accept the reality. Accepting reality involves accepting that unusual manifestation of something common, like gouty panniculitis. And then as we are ruling out common things and unusual manifestation of common things, we're invoking something real like PPP syndrome. So this case highlights the importance of keep crowding differential diagnosis in patients presenting with polyarticular disease with atypical presentation. And as mortality rate is high in this patient, early diagnosis and therapy of underlying pancreatic disease is crucial. So I recommend that all of you, when you deal with patients present with panniculitis and polyarthritis, even without GI symptoms, we call it as asymptomatic elevated lipase level, to consider PPP syndrome. And yeah, and I will stop here. Thank you, guys. And I
Thank
hope
you,
I
Abhi.
find it informative. And this is my references.
All right. Thank you. We're sorry for the interruption earlier on. I thought you were done. Thank you. That was excellent, fantastic teaching. Everyone loved your graphics and the way you broke down the whole PPP syndrome into parts and explained and went into the depths of the pathogenesis and how to diagnose it and how to pick it. And also, a very key point for clinicians is to be open-minded and to know that it's not always going to be a textbook case. So you should suspect PPP syndrome even in the absence of GI symptoms. That for me was a very important take home. And then I also am going to try and always remember the 3 Ps in the PPP syndrome: pancreatitis or pancreatic malignancy, panniculitis, as well as polyarthritis. And I personally know the amount of hard work that went into this presentation, Abir, and I really appreciate your efforts. Also, I know that you're under the weather today and you were still able to join us. So thank you once again. And here we are reaching the end of the session and on to our third presentation for the day. And this is no longer a surprise. And I'm about to reveal the next presentation. And the presenter is your and only almost myself. And I'm going to be presenting the third CP recap. So I will get started and share the screen. Just a moment. All right. I have to say, facilitating is not hard at all. Presenting is difficult. Right when I shared my screen, my heart started thumping and I have tachycardia now. All right, guys. So today's topic is altered mental status, the approach to altered mental status in a clinical practice. Can you all see the screen? Just give me a thumbs up. All right. Okay, so this topic is something that pops up very commonly in the clinical practice, and I feel like every other VMR in the CP solvers community, at least every week we have a case of altered mental status. So I wanted to kind of go over the generalized approach of this, and my aim today is to deepen the understanding of what is altered mental status. And I have picked not one but two cases to kind of correlate real world scenarios and the way they're presented in the CP solvers community to correlate with this very important a symptom or a chief complaint that we encounter in the ERs and in the wards. So I'm going to start off by asking you guys to kind of close your eyes and think about altered mental status. What is the first thought or what is the definition that you have for altered mental status? and you can go ahead and type out in the chat, but this is just a mind exercise that I want you to do. And I'll share what comes to my mind when I think of altered mental status. So in the books, and if you search it up, there is no definite definition for altered behavior or confusion. So there is no definition. But what is altered mental status? This is basically a complaint that presents in clinical settings when an individual's behavior is observed to deviate from their baseline or according to the societal norms. Now, these observations can be made by the patient's family member or caregiver or even the law enforcement. So this is how these patients present to us, and many times they lack awareness of their own altered state. Now, altered mental status consists of certain conditions, and the key concepts when we talk about AMS include number one, delirium. So when you think of delirium, this is an acute and fluctuating change in the attention and overall mental status. Delirium may accompany other cognitive disturbances, and it varies in its presentation over time. The next entity is agitation. So many patients exhibit agitated behavior, which could stem from an underlying psychiatric condition or specific toxidromes. And it's important to note that agitation itself can occur with or without concurrent delirium. The last entity that I want to go over is dementia. And unlike delirium, dementia is a chronic progressive decline in cognition. It is characterized by a gradual onset. And dementia, again, may also include behavioral changes. A patient who has dementia may be agitated, may have delirium, and this would then further complicate the diagnosis and management. So that was about altered mental status. I will delve into my first case. This case was presented by Amal Naji on 19th of April. And this was one of those odd RLRs where one R was missing. So Ravi was off to vacation and Prof. Rez happened to be the only discussant that day. So this patient was a 60-year-old male with a past medical history of chronic alcohol use who presented with acute altered mental status, hypothermia, and hypoxemia. Its physical exam revealed diffuse crackles in the lung, irregular heart rate, a non-blanchable rash on the lower extremities, and then the initial workup showed findings like leukocytosis, anemia, thrombocytopenia, acute kidney injury, and all of this was raising concerns for septic shock. Eventually, our patient was diagnosed with sepsis, with DIC, which was likely secondary to E. faecalis and Staphylococcus lugdunensis. I hope I said that correctly. This whole picture was also complicated further by his acute alcohol intoxication. And to make things even harder, he also had ARDS, and all of this necessitated the use of respiratory support and antibiotics. And this was the first case. I will reflect onto the clinical correlate and link it up with AMS later on. But this was a case that presented with AMS and ended up with a diagnosis of an infection. So here's the final diagnosis. I will move on to the next one. The next case was also another RLR, which was presented very recently by Zachary Owens on the 3rd of May. And this was also discussed by Rabi and Reza. And in this case, we had a 53-year-old male who was status post bilateral lung transplant secondary to sarcoidosis, past medical history of ESRD, no cardiac bacteremia that was treated. And now this patient was presenting with AMS. Physical exam revealed postural tremors, bradykinesia, and later on, when they did a brain CT for this patient, it showed an enhancing lesion in the left basal ganglia, and CT of the chest showed a right middle lobe opacity. And so the final diagnosis for this patient was post-transplant lymphoproliferative disorder with CNS involvement identified as EBV positive large cell lymphoma. So these were the two cases, and both of these patients presented with altered mental status. And sometimes in RLRs and even outside of RLRs in clinical setting, when we talk about the approach to AMS, the mismnemonic pops up. And oftentimes when I'm doing the teaching point, now I've memorized it. I'm sure those of you who are regular attendees of the VMRs know the mismnemonic by heart and know that Rabi and Reza often bring it up every time we have an AMS case. So today I want to touch up on that. This schema that you see on your screens is from the Clinical Problem Solvers website, and it is available for everybody to access. It comes with a small video where Rabi is going also teaching the schema, but today I will take the role of Rabi and teach this to you guys. So this is AMS 1.0. and I'm going to jump onto AMS 2.0 later on. So let's simplify the mnemonic. M stands for metabolic, I for infection, S for structural, and T for toxin. So these are the different etiologies that should guide you towards the diagnostic and management approach of a patient with altered mental status. So when you talk about metabolic causes can range from electrolyte imbalances to severe organ dysfunction. So you always want to start off by checking a blood glucose and doing a basic metabolic panel, right? And why are you doing the basic metabolic panel? You're trying to see and rule out if there is a hypo or hypernatremia, uremia, hypo or hyperglycemia, the arrows that you see on this diagram, and finally hypercalcemia. Then we have some other causes in this bucket, which include hypercarbia or hypoxemia. And then lastly, a very common etiology would be hepatic encephalopathy. Moving on to infectious etiologies, infections can be divided into outside the CNS and inside the CNS. And I love this approach from the clinical problem solvers because I've read up different ways of approaching the infectious etiology. This one being my favorite. It's simplified, it's easy to remember. When you think of causes outside the CNS, the most common ones are pneumonia and UTI, especially in the elderly. And inside the CNS, we have encephalitis and meningitis. Then we have structural etiologies, and one of the most sort of life-threatening and urgent ones that you want to rule out in an ER are subdural hemorrhage. And so you want to go for a CT scan to rule this out and to look for other localized lesions in the brain. And lastly, we have toxins. Toxins can include things like opiate overdose, things like alcohol withdrawal. And so you want to start off by doing a urine toxicology screen. Now, how did this schema or this mnemonic help our cases that I was just talking about earlier on? So case number one, we were reflecting more towards the M and the metabolic and the toxin side of the mnemonic. And so this patient had hypothermia, had potential alcohol withdrawal, and needed immediate management. And in the end, it turned out to be the infectious etiology. So that is how this mnemonic guides your diagnostic approach, and turns out that this was the I in the mnemonic. Another very important thing that I even remember from that day, because I was doing the teaching points, was the focus on alcohol, the use of alcohol in this patient, and that itself can cause altered mentation in patients who use alcohol heavily, and that itself should prompt immediate consideration of both the direct and indirect effects of alcohol and its complications, which would then include metabolic disturbances like hypoglycemia. So you see how this one case is kind of touching upon the different buckets in the mnemonic. And talking about the second case, in the second case, we were focusing more on the structural and the infectious factors, right? And then in the end, just a second. The missed approach finally led us to the discovery of a structural lesion within the brain, which was a CNS lymphoma, and that guided further treatment. So completely different cases with the similar approach led to the diagnosis. And I'm going to move on to AMS 2.0 and ramp things up for you. So when AMS, a simple mnemonic is not enough oftentimes, and there's more to it than just those etiologies. So when you have a patient with AMS, the first and foremost thing is to not diagnose and to not start by doing the workup. You're in the ER, you want to manage the patient, you want to see, do I have time to do something, right? What can I do to save my patient? So you want to look at the life, first of all, you want to see, is this patient really a case of altered mental status, or is this an AMS mimic? And those mimics can include things like aphasia or dysarthria. The second most important thing, especially in an emergency setting, is to rule out life-threatening situations and manage them. So you want to ask before you can do anything else. And three of the more common presentations that are easily corrected include hypoglycemia, which can be corrected with a D50. And then we have opiate overdose, which can be reversed with the administration of naloxone. And then finally, patient who is so altered that they're unable to secure their airway, and then you want to intubate them. And imagine you're not thinking about that and you're moving on to your mnemonic and you're thinking about all of that. So it's important to kind of think about that. So here's AMS 2.0, and I will not repeat everything I said earlier on, but kind of highlight the new parts to this schema. So we've talked about the electrolyte imbalances. There are three main parts of the metabolic bucket. The electrolytes we've already gone over. The organ dysfunctions can include the lungs. We've talked about hypercarbia and hypoxemia. You have the liver. We've talked about hepatic encephalopathy. You want to check the kidneys and see if the kidneys are doing okay. So you want to do the RFTs. You want to do an endocrinology assessment, so you want to look for the TSH, the cortisol. You want to do the ABGs, the venous blood gases, and then also how can I forget the heart? You want to do the troponins. You want to see if this is acute coronary syndrome. So those are some of the things, key things to keep in mind. And lastly, the thing on the bottom actually holds a lot of importance as well. So many times people with a deficiency of thiamine, which can be easily corrected, present with altered mental status, and you can administer thiamine. Patients who are chronically malnourished or who have chronic alcohol use disorder can also present with Wernicke's encephalopathy, and that would need thiamine. Then the last two categories, urinary retention and constipation, hold special importance in the elderly population. So you want to be very, very mindful of these two. We've gone over the infectious, we've gone over the structural. This last topic that I will focus on is how to approach the T in the mnemonic. So when you're thinking of toxins, there's three different ways you can approach this, as Ravi teaches. So the first approach would be to see, is this toxidrome due to toxin that was prescribed, due to a drug that was prescribed, or is it due to a toxin that was overdosed? The second way to approach this is there an overuse of this drug or toxin, or is there a withdrawal of this drug or toxin? And lastly, is this a UTOX positive toxin? Can it be detected on a urine toxicology screen, things like OPH, or is it going to be a UTOX negative culprit like ketamine or methanol? And that is it, guys. This was a generalized, simplified approach. Thanks to the CP solvers. Whatever I taught you guys today, is something that I have learned from the CP solvers, and I am very, very grateful for all of the teaching and the learning that goes on. And so I'm going to give you some teaching, just quickly going to summarize today's lesson. So an effective approach to altered mental status would be distinguishing true AMS from its mimics, prioritizing life-threatening conditions. The importance of a thorough history, and you will hear oftentimes here Rabi and Reza and some of our other discussants, focusing on history is king, history is king. So remember, taking a thorough history can give you a lot of information and save you a lot of time. And then lastly, employing the mnemonic approach. So, if this is your first time, start with the AMS 1.0. And if you're bored of hearing miss, go for the AMS 2.0 and take a look at it. And this is it, guys. Thank you so much for listening to me. I will end by just giving a shout out to the CP solvers. And this is a quote that I really liked. Tell me and I forget. Teach me and I remember. Involve me and I learn. And I feel like in the CP solvers community, you have a bit of everything. You get to teach, you're involved, and you're interacting and you're learning. And thank you everyone for joining us. And I will see you again in another TP Recap VMR. Bye-bye, guys. If you have any questions, I'm here for another few seconds to take care of them. But otherwise, this was a lovely session. Goodbye.